just introduce myself. My name is Kyle Reed. I just finished my second year of medical school, studying for step one. So I guess I'm between my second and third year. I don't really know what to call myself right now. But it's my pleasure to welcome you all to this event to, celebrate the work of Dr. Gore and explore his experiences and, his life as a physician and what's brought him to this point today and the work that he's doing and the work that he's going to continue to do. So we wrote a little synopsis, I guess, of what his lived experience and what he's done. So I'm just going to read it off. So Dr. Robert Gore is a dedicated emergency medicine physician and active community advocate. He earned his undergraduate degree from Morehouse College in 1998, followed by his medical degree from the University of Buffalo in medicine and biomedical sciences, graduating in 2002. He later served as the chief medical resident at John H. Stroger Jr. Hospital of Cook County. With nearly two decades of experience, Dr. Gore has been deeply involved in creating and advancing programs aimed at addressing community violence and other health disparities that both impact urban and global populations. His efforts have earned him the title of CNN Hero and a spot on the Route 100 list. He's the founder of CAVI, King's Events Against Violence Initiative, an in-school, hospital, and community nonprofit anti-violence program that looks to teach young people how to resolve conflicts peaceably. The work that he does is critical to the Downstate community and makes Brooklyn a safer place. So now I'm going to hand off the mic to Dr. Gore himself so that he can give his own introduction.
Thank you. First of all, I want to thank everybody for coming. Since there's not a lot of us in here, we can have a really nice, intimate discussion. I know we have competing circumstances today. I know the community board meeting is going on right now, which is essential for the survivability of this hospital, which is essential for the survivability of this community. So I want to thank you all for taking your time out and coming and being with us today. Since we don't have an exceptionally large group, I want to make sure we can have more of a Q&A and really have a really discussion rather than a lecture format. I know the medical students are really sick and tired of being in lectures all the time. The residents don't have the attention span to do that stuff for long periods of time anymore, especially since I know the emergency medicine residents had their in-service yesterday. Congratulations, Derek. And so I know you already lectured out, so I don't want to make this into something that's going to beat everybody in the head with, but I do want to share some of my experiences. It's kind of weird, listening to some of these bios, and I see the bio all the time because I send it out to people, but I felt really old when you said I've got like 2 decades of experience, because now, and I realize I have to update that because it's actually more than 2 decades worth of experience doing this stuff. This is my 23rd year as a physician, and Dr. Guillen and I were chatting. We met each other when we were medical students. I was in Buffalo. She was here at Downstate, but we met at the SNMA conference in Miami back in 1999. So that's a long time ago. It doesn't seem like, I know there are a couple of gray hairs in the building and in this space, and we go, 99. That was just like, oh shoot, that was more than 20 years ago. But for you guys who are a little bit younger, it does seem like a long time ago, but you really don't understand the power of connections and how you build community and how people are going to kind of intertwine with your lives and how you're going to work together to really solve common problems. All these people you're in residency with, all these people that you see up and down the halls of this hallowed institution are be people that are going to be a part of your team in helping solve more complex problems, which is kind of why we're here. I grew up in downtown Brooklyn in pre-gentrified Fort Greene and in Flatbush. I actually went to PS 235, which is directly across the street from Kings County Hospital and Downstate. And I've been a patient at Kings County Hospital. I've been a part of this community. I've been chased all around East Flatbush. And for people who grew up in the 80s and 90s, when we say chased, we really do mean chased, like physically chased, like having to run because folks are trying to get you because you have something that they want, or they just want to take advantage of a skinny kid, but they don't realize you run cross country and you can keep this pace up for more of an extended period of time. But I've been at Kings County Hospital, and I recently left SUNY Downstate practicing clinically, but I started working here in 2006. It was my hopes to come back here. I did my residency training in Chicago at Cook County Hospital, which is the hospital that the TV show ER is based off of. Chicago, much like Brooklyn, is a big urban space There's a lot of crime, there are a lot of amazing people, but you have this demarcation between the haves and the have-nots. And anytime you have that demarcation between the haves and have-nots, conflict occurs, violence occurs. And when you're a student, or actually when you're a concerned citizen, and you are navigating the community which you work in, that you're navigating the community in which you have to take part in because of schooling, or just going through as a part of transportation, you're assessing your environment, you're thinking, who am I? Can I get home safely? Can I get to my destination safely? Can I get home safely? I realize that doesn't happen to everybody. But as a kid growing up in the 80s and 90s, safety was always a major concern. And it wasn't until I became a medical student in Buffalo and I started to have these very intimate experiences with patients and members of the Buffalo community that I realized, even though I'm a student, I have a voice. Even though I'm a student, I represent something greater than what I even realized in myself. I was a conduit and able to help people pass on information and help understand information that might save their lives. It's a big responsibility. And for all of us here who are in medicine, and even the students, you can't really fathom that. But when you're a student and somebody they're scared, they're terrified, they're in these clinical spaces, they're looking for something familiar, they're looking for something comforting, they're looking for somebody who can establish rapport, they're looking for someone who can translate what's happening to them in a way that's palatable for them to synthesize and understand. And that would happen more and more in Buffalo. I was actually born in Buffalo, but I was raised in Brooklyn. And I never lived there until I was in medical school. And so I didn't really understand the dynamics and understand what took place in a Rust Belt city until I would hear this concept over and over about the Rust Belt, Rust Belt, Rust Belt. And you think about blue-collar towns, but New York City is not really a blue-collar town. You've got people who are working class and in different kind of industries, but there's not one major industry here. In Buffalo, when there's a factory or there's a business that shuts down, entire communities get affected. And same thing in Ohio, same thing in Baltimore, Pittsburgh, and we've seen that take place. But Buffalo had a steel industry. And when the steel industry shut down in Buffalo, everything shut down. And poverty started to increase. In areas that were once flourishing, because I remember going to visit my grandparents who were between Queens and Buffalo. I would go visit, and I thought I was going to like the country because they had grass. And I didn't live in East Flatbush. East Flatbush, they got houses. Downtown Brooklyn, they no houses. Nobody has grass unless you go to Fort Greene Park. But I would see this stuff, and I'm like, wow, this is a really cool place. I could ride my bike in the street. Then when I got up there for medical school, everything was shut down. McDonald's had shut down in the downtown Buffalo. Poverty was increasing, and because poverty was increasing, the health disparities were also increasing. I started seeing young people who looked like us who were coming in as victims and survivors of trauma. And I decided that was going to be something that I was going to take on, looking at health disparities, but I really wanted to do this stuff more on a global level and doing more global health. When I moved to Chicago, I saw violence and trauma that was only comparable to what you would see in war. As a matter of fact, we had soldiers who would come to Cook County Hospital's trauma department and spend time with us before they were being deployed out to Afghanistan, before they were being deployed out to the Middle East. I can't remember what it was. It was the Gulf. It was the Gulf War. And what's the other one? Iraq. I can't remember which one it was because all these things are starting to blur together. But we had soldiers coming in repeatedly. The same thing even happens here at Kings County. But when I was a resident, I had an epiphany. As resident physicians, we always want to do procedures. We want to learn certain skill sets because this is going to be important for us as future professionals. But one day, it was actually kind of like this. It was in the 50s, and it was cold, and it was raining, but it was August. And August is usually super hot. It's like 80s, 90s, 100 degrees weather. And this day was a little bit different because it was cold. And I was on call in our trauma emergency department, and there was nothing going on. I was going to be there for a 24-hour period. And, you know, Derek, who's one of our emergency medicine residents, knows what it's like when you have a bunch of people who have ADHD in one space who are bored. They start fidgeting. And remember, this is 2005. So we had social media, but you had to log in on AOL. And there was something, I know there's something called Black Voices, which is like the precursor to all these different chat rooms and stuff like that. But this day, nothing was going on, and one of my co-residents said that he was bored. And so a bunch of people were like, oh yeah, we're bored. And then he said, I want something exciting to come in. And a bunch of people in the room were like, yeah, we want something exciting. Yeah, yeah, yeah. Everybody got riled up and they were laughing and joking. I was a chief resident, so I really didn't want anything exciting to happen because I had paperwork to do. But excitement means people get to do procedures. They go to the OR, they get to intubate, they get to sew up somebody's face because they got a $1.50 scar. And $1.50 scar is when you get a scar from a razor blade that comes from your ear all the way down your mandible. And they said it takes about 150 sutures, 150 sutures, so we call it a $1.50 scar. And I'm looking around the room, and the only two people of color in the room are me and one of the clerks. All the patients that were coming in were Black and Latinx or Eastern European. Patients came from the south side of Chicago. I lived on the south side of Chicago. Patients came from the west side of Chicago. I had family who lived on the west side of Chicago. My father was actually born at Cook County Hospital. And I always wondered if I'm in the wrong place in the wrong time, are the residents going to be excited because I'm coming in? If one of my family members come in because some of them were involved in some illegal activity, I wondered if they come in and my co-residents going to be like, yeah, we got something exciting because we get to crack somebody's chest open. Not really thinking this is a person who had thoughts, feelings, family, connections. But I felt like the residents were looking at these patients, at our patients, the people in our community, as science experiments. And although I thought it was important as an emergency medicine resident to learn how to master these different resuscitation skills, I started thinking what would happen if we made sure that people didn't have to become patients. And I started learning about the work of Dr. Arthur Kellerman, who was the chairman of emergency medicine at the time at Grady Hospital. I started reading about Dr. John Rich, who was an internal medicine doc, who's now the center for one of the health equity programs at Rush University, but he was at Boston City Hospital at the time. And these are the first two people I'd ever read about talking about violence as a public health problem, violence as a disease process. So if we understand what the disease is, if we understand the risk factors, we intervene and we make those changes with those risk factors, we can substantially diminish the number of casualties that are coming about with violence. And so I started doing deep dives. I'm looking, I'm researching, I'm pulling articles left and right. It's the first presentation that I think I had started researching way ahead of time. My senior grand rounds wound up being on youth violence. And I think I spent about 5 or 6 months researching the topic because it was something that was so important. Homicide back then and now is the #1 cause of death for Black men ages 15 to 34. So Black men in that age bracket are more likely to die from homicide than any other injury or illness. And when you're concerned about your personal safety, all of a sudden it takes on you have a very different outlook. And so I started doing these deep dives. I did my presentation in my senior grand rounds, and my faculty and department just had their mouths closed because nobody ever thought about, wow, these patients that are coming in that we get excited about, we're cheering on them, and we didn't take into consideration how the other students of color felt, who were connected to the community, who might even actually know some of the patients who were coming in. And shortly after I came back to Brooklyn, I started working in Kings County and Downstate, and my goal was to create a violence intervention program. It took a long time, a lot of blood, sweat, and tears, a lot of connections, a lot of researching, experimentation, learning, relearning, getting out of comfort zone, and eventually we wound up developing a program called CAVI, which is the Kings Against Violence Initiative. I should probably take this off so you can see our logo. And CAVI is a hospital, school, and community-based violence intervention program that focuses on really reframing these conversations that we have around violence and trauma. We have 3 different components: the hospital, school, and the community program. I have to say also, I got to give a shout out to the people at SUNY Downstate, because if it weren't for the people at SUNY Downstate, this wouldn't have launched. CAVI got started partially because people from the School of Public Health here at Downstate said, I know you're doing all this work on violence intervention and you want to create a program. We have a School of Public Health, and our students have to do 200 hours of field work in order to graduate. If you can use the students as much as you want for your program, I was like, great, thank you, because I didn't have any money. And I made the decision to start this without having any resources because I got tired of people telling me no. This recurrent conversation, this recurrent theme was, wow, that's a great idea, no money. I said, we're going to do this intervention program in the hospital. We're going to make sure people don't retaliate because we're going to provide case management and resources and support for patients, because we know when people get support, they don't come back. That's one of the social determinants of health, having social support systems. And then case management, they were like, wow, that's a great idea. Sorry, no money. I was like, but somebody gets shot or stabbed, the rate of retaliation, the rate of re-injury is 40 to 50% within 5 years. And they go, man, that's crazy. Sorry, we ain't got no money. And I was like, but somebody gets shot or stabbed, the rate of them being killed is as high as 20% within 5 years. And every time they get an injury, that rate jumps up. They go, oh, man, for real? Sorry, we ain't got no money. I was doing a lot of stuff in global health. I was working in Haiti. I've been to Haiti probably about 14 to 15 times. And we have been training drivers and laborers in first aid and emergency response, really the foundation of a pre-hospital system in the north and northeastern part of the country. I've done patient care in pre-earthquake, post-earthquake, working in the 10 hospitals. But one of the things that anytime you do any kind of intervention, and this is for the residents especially and the students, especially the public health people, I know you guys already get that. You know, that's something, these are things you know, but capacity building is highly important. What resources can you provide? What interventions can you provide that are going to be long lasting and allow the community that you're working in to be able to do this stuff independently of the resources coming from the outside space? How do we have a self-sustaining model that can be supported by the community without requiring outside input? And so your goal as physicians, as public health workers, as educated, as community people, is to really become obsolete. So if the interventions that we're providing aren't really leading into that direction to ensure that the patients don't need you in the future, if you're not working towards those levels of independence, then we are poverty pimps. And we have to be really conscious and mindful about what it is that we're providing. There's a student, I did a talk at BMCC yesterday, and one of the students, I asked him what kind of problems that he hoped to solve in the future. And he talked about doing business, but he said, I want to make sure that there's morality before money. And I was like, man, that's a beautiful statement to hear from an 18-year-old kid who's at BMCC. He said, morality before money. Because if we wind up creating programs, we wind up creating businesses that are sustainable, and we have the people, particularly those who are most vulnerable in mind, these things wind up having a way of working themselves out and continuing to improve and continuing to grow as be a part of these movements that really can't be contained. And so we have to consider capacity building and what that means in our respective specialties and areas of discipline so that we can become obsolete. So I was doing all this work in Haiti. At the same time, I was doing a lot of work. I was doing all the violence intervention work. I'm going around the city, around the country, talking about violence and trauma, and really just because I didn't have any money, but learning how to speak in front of different audiences. I talked to whoever was available, little old church ladies, people at temples, young people, high school students, middle school students, teachers, educators, physicians, surgeons, public health people, nurses. And I didn't realize how important it was to actually reach these different audiences because these were members of the community. And these are the people in the community who would support patients. And we needed to make sure that we addressed their needs and concerns to really create something that was meaningful. When I came back from Haiti, this was around 2011. This is probably trip number maybe 6. Let's see, I first went down in 2009. So this might have been trip number 6 or 7. And I came back, and even before that. So Dr. Daniels and I met each other in 2009. And the reason why I remember it's 2009, because 2009 I launched a pipeline program called MMSEM. MMSEM is an enrichment program, a 6-week program focusing on program development and early exposure to emergency medicine for students of color with a focus on project development. And I had all this information and all these papers that I had been working on and presentations that I've been doing, but I didn't have an actual program. We were doing advocacy work, really just talking about violence. Me and another guy named Dr. Austin, and some of the people who are a little bit older in this room may know the legacy of Dr. Austin. Dr. Austin is a graduate of SUNY Downstate. He's one of our first emergency medicine attending physicians over at Kings County. He's now retired. So he and I were doing a lot of this talking, and there were people who were doing a lot of that work with him beforehand, but we still didn't have any money. And we got rejected and rejected and rejected. 2009, I launched MMSEM, and the first project that the students in the program were doing, I said, look, I need some help developing this violence intervention program. This is what we're doing, and they helped me work on other formalized presentations. And then the final presentation over at Kings County Hospital in the Department of Emergency Medicine, the students presented their work for the summer. They said, we have this program we've been working on, the ins and outs, and we're going to call it CAVI. So CAVI actually itself came from medical students from SUNY Downstate who came up with the acronym. Kavi itself is a Sanskrit word and it means thinker, doer, and poet, but it also means Kings Against Violence Initiative. So they actually gave some sort of foundation, which became a new nidus and really reignited what we were doing. Now, still doing all the global health stuff. I was working like a crazy person. 2000, I was still a residency director. I was also single. And I was screwing up a lot of relationships, and I was throwing myself into work because I was pissed off about my relationships not working. You know, people in the back laugh, and they understand because they've been there too. But in between me sabotaging in 2011, I had sabotaged another relationship. But I came back from Haiti, and I was talking to my dad. My father has a background in television production and media, but he's also a community organizer and activist. And he had been doing activism work since he met Dr. King in the 1960s. He was about 17 years old and met Dr. King at a youth retreat and came back home to people on the west side of Chicago talking about this is the kind of change that we're going to be implementing in the community, and started doing more really, really comprehensive organizing in and around the Chicago community and beyond. And so, and he's old now and doesn't hold any punches and has no filter. And I came home, I just finished meeting with Dr. Maurice Selby, and you know Dr. Selby. Dr. Selby is an attending physician. He's one of the assistant program directors at Grady's emergency medicine program. And we had just gotten rejected from another grant. And I was pissed. So I went over to my pop's place over in Flatbush, went up to his apartment, and he's sitting in this chair, and he's reading a magazine. I think he's reading like Life magazine or whatever, Time mag, something. And I'm like, man, Pop, I was like, these mofo, I use a lot of bad language and stuff. I don't curse around my parents. You know, I'm pretty respectful in that space. And without even like taking his eyes up from the magazine, he said, why the hell should they give you any money? You ain't done nothing. He said, all you've been doing is talking about the program. And my father's been working with us on the Haiti projects. He's actually the person who even got me to go to get down to the country to begin with. But he said, you've been talking to a bunch of academic people about stuff, but you haven't done anything. And I was like, damn, that's kind of harsh. But he was right. I was looking at this through an academic and theoretical lens. And he said, here's some magazines, go take a look at it. And he gave me a copy of Incorporated Magazine, INC. He gave me a copy of Fast Company. And there were a bunch of articles talking about startup companies and what that culture was like. And I was like, huh. And I sat there and I was like, oh shit. I was like, I'm really focusing on being an academician. I'm not talking to the people. I'm not even working with the people. I'm getting an opinion of people in these spaces, but not doing anything. And one thing with startup culture that you realize is you just have to start. In medicine, as medical students, as scientists, we are afraid to make mistakes. We want things to look a certain way. You wouldn't even get in medical school, public health school, doctoral programs, unless you were OCD, unless you had like top grades. You might have screwed up a little bit, you know, like in junior high school, like I did, and be threatened to go to military school, then had a major turnaround a little bit later, but you were still kind of OCD and you had different kind of regimented ways of studying. And if you got something wrong, you were like furious. But what that does to a person is that you think that making mistakes, that there are casualties and there are problems with that, rather than looking at it as a natural process. And I was learning a lot about engineering and design thinking and startup companies. And one of the things a lot of these folks aren't afraid to do, they're not afraid to make mistakes because they don't look at it as making mistakes. Engineers look at it as a part of the process. It's like, oh, you're supposed to, fail at your prototype. You want to fail, and you want to fail quickly. There's a medical student named Subhashi Patel. He's now an attending physician. I think he's working in the industry, but Subhashi was one of my medical students a number of years later, and I was working on some ideas. This is when our presidential administrations changed and there was no longer funding for Black and brown programming, and I was trying to figure out ways to do some stuff tied to innovation and design and figuring out how do we bring this stuff to the forefront so people would solve problems in efficient ways. And Subhashi said, you're trying to create engineering design process. And I was like, what? I've been racking my brain on something that was already in existence. And he said, engineering design process is a way in which us engineers solve problems. Before Subhashi went to medical school at Downstate, he was an engineer and an inventor and had a bunch of patents. And he said, what it starts is that the first thing is you got to figure out what is the problem you're trying to solve? What's the idea? Then after that, you come up with a series of brainstorming ideas. We all like to brainstorm. We like to throw ideas out. We gossip, we talk, and do all that stuff. But sometimes it just keeps going and going and going because we don't put these ideas in a finite space to actually just put a halt and review and revise and look at and interpret these ideas. So you come up with the idea. What's the problem I'm trying to solve? The second step is you brainstorm different potential solutions. Then after that, and this is the part that we as physicians and medical students fail at, you've got to create a prototype. You've got to come up with a series of different prototypes, and then you've got to test it. But it's not supposed to look pretty, because if it looks pretty, what happens if something looks pretty and you've written? You've done this nice grant proposal, what happens? You're afraid it's going to crash. So when you give it to somebody and they write red pens all over it or edit it in, now we don't have to write red pens. It gets demolished, you don't want to do it anymore. You fail your in-service, you don't want to study anymore. I don't want to be a doctor anymore. Attending physician corrects you in public. Oh, I don't want to do this anymore. I got pimped. I can't do this anymore. And you avoid that attending, you avoid that person, instead of looking at it as a learning experience and realizing that we're dealing with people's lives, and I want to make sure that we correct you in real time so that we can continue to grow faster, stronger, and be more effective and more efficient in the work that we're doing. So once you create these prototypes, you got to test it out. When you in business, they call these MVPs, minimum viable product. And the minimum viable product is something that shouldn't take you more than 6 weeks to implement. And you got to start it. It's got to be gritty. The reason why when we look at our phones and we have all these updates, 1.0, 1.2, we have all these bugs you got to fix, is because they're troubleshooting. And they're troubleshooting in real time, and they realize, oh, we got new information. We have a new way of looking at this problem from all these different angles. Let's fix this problem. And they go, okay, 1.0, 1.1, 1.2, 1.3. You have to look at the programs that we implement. Even as resident physicians, when you treat somebody, you don't want to look at somebody as a science experiment, but when you try something and you fail, you can't just get paralyzed. That's the reason why we have these algorithms, our primary survey, our secondary survey, because when things get stressful and we start failing, we kind of got to go back to the basics. And that's the same thing with design when you're as a part of this engineering design process. Once you test your prototype, you have to ask yourself, did it work? If it worked, great. Let's see how we can do it more effectively and more efficiently the next time. If it didn't work, we have to evaluate what do we need to do to change our process. But you got to fail, and you got to fail quickly and get accustomed to not even failing, get accustomed to doing these different things, because there are people who are going to benefit from your mistakes in the future. They're going to benefit from your areas of expertise. And if you don't wind up implementing these things, these programs, these new ideas, there are people who will die because of that. The way healthcare is right now, we're spending a whole lot of money. I do emergency medicine, but I kind of feel like I'm emergency medicine and a primary care physician at the same time. I feel like I'm a public health expert, even though I don't have a degree in public health. I just kind of do the work, which I think is probably more important. Are you going to do the work, or are you going to intellectualize about these different processes? So after having these conversations with my dad about not having any money and about making sure I'm doing something that's directly impacting the people rather than speaking to academicians, I called some people and we decided to launch. For a number of years, we were really trying to create a hospital-based intervention program providing support for victims and survivors of trauma, much like what we do right now. But there are a lot of politics when you work at any kind of government institution. Some people like the work, some people don't like the work. Nobody wants to front the money. And sometimes you just have to start before people really understand the vision of what it is that you're trying to do. So we decided, I said, through all the politics, we're going to start at the school. We're going to make sure that people don't have to become patients. So I called a couple of people I knew at Wingate High School's campus, which has issues with violence. There are a number of different high schools on that campus. And I called a friend of mine who was a guidance counselor, and it was her last day on the job. And she's like, I'm glad you called me because I'm leaving. I was like, I want to start the program at your school. I want to test it out as a pilot at your school. She said, oh, man, come over here right now. Are you around? I said, yeah, I'm in my office. So I ran across the street, and she introduced me to the principal. I said, I want to do this test program with the kids that you're having problems with, the kids who have histories of frequent fighting, doing poorly in school, gang involvement. These are all risk factors for violence and recurrent violence. The principal was like, great. And he was like, how much is it going to cost? I was like, it ain't going to cost you nothing. It's going to be free. He was like, even better. So I said, just give me like 2 students, and I'll work with them. Because I had somebody who was going to be coming from Downstate, because Dr. LaRosa made that happen. I was going to have somebody coming from Stony Brook as a social worker graduate student. I like working with grad students because they want letters of recommendation, and they don't want to screw up. And they're OCD, and especially the people who want to do research long-term, they can be effective and efficient, which balances out us ADHD emergency medicine types. And it also can provide a different kind of structure. So we reached out and decided to have 2 students that we're going to be working with over at Wingate High School's campus. School sent us 6. And then every week they sent us more. And I remember after like a couple of weeks of doing these workshops, in our school-based program, we have an entire curriculum that focuses on conflict resolution, mediation, skills development, idea development, a lot of social justice stuff like understanding power and oppression, but a lot of life skills are going to really give practical and tangible skill sets that are going to help you navigate spaces where you have to understand mediation and understand how to engage in conflict. And so 32 weeks, we're going to be doing that, but this is like week number 3 or 4. We were only supposed to be there like 4 to 6 weeks. It's just supposed to be a test pilot that we were going to eventually start to do as an after-school program. But after a couple of weeks, one of the students said, "You guys are going to be coming back." And I think it was right after like that 4 to 6 week mark. He's like, "You guys are going to keep coming back, right?" And I was like, "Oh, shoot, we're on to something." Because we were never supposed to start a school program. It came about by default because I couldn't enter and do the work in the hospital. But once people started seeing pictures of what we were doing in the school program, they wanted us to be able to, "Oh, yeah, do the hospital program." I started pulling people. A friend of mine who's actually still working with us, I met him in the emergency department because his kid got bit by a dog, but I noticed that Benny had a $150 scar on the side of his face. And I know he had had some challenges in the street earlier just by basic observation. And Benny became our first volunteer doing intervention work in the emergency department as a volunteer. And we did it as a volunteer-based program for 2.5 years before we even saw the first dollar, before the first donation. But while we were doing that, because we created something. It was a living, breathing product. It was a living, breathing program. It wasn't perfect by any means, but it was a start. And then once you have things in place, people can go, "Oh, this is not working. You need to do this. You need to do this. You need to fix this." And so we're becoming better and more efficient. I practice Brazilian Jiu-Jitsu, and I also practice Judo. And there are 2 tenets in the sport of Judo. Actually, there are a few different things in Japanese that I think are important. One is called Kaizen, which means constant, never-ending improvement. But specifically for Judo, there's one, Jite Kaioi, which means mutual benefit. And the other one is Serioko Zenyo, which means maximum efficiency and minimum effort. So anytime you're engaging in a partnership, when you're working with patients and families, when you're working with people out in the community, when we are the person who may have a different set of degrees, we have a different vocabulary, and we kind of think we're in a position of power, we assume that you're supposed to listen to what I'm telling you. Rather than us coming into this space, and even when patients coming into the ER or in the medicine department or on the floors, we're really engaging in an actual partnership. And so there has to be a mutual benefit. If there's no mutual benefit, there's no relationship that's building. There's no rapport that's being building, and people don't understand. They understand that you're not in this because you're not trying to give me something that I actually need. You're giving me something you need. So when I have residents, Derek knows, when patients come in, I ask them, "Well, first thing, I'm like, what is it that I can do to help you, make you feel better right now? Let me get you look like you're throwing up, you look like you're uncomfortable. You want something for pain? Yeah, cool. Let me get you that first. Then after that, we have our regular conversation about what's going on. I've given them what they needed. And for people who are in partnerships and married, you understand how that is when you don't ask your significant other what they need and you just try to give solutions. You sleep on the couch, you get in trouble, you get the cold shoulder, and they get pissed off at you for a long period of time. Maybe like 2 or 3 days, but it seems like a long period of time when you're under one roof and in a very enclosed space. So you have to make sure there's mutual benefit with any kind of relationship. But then the other thing, maximum efficiency and minimum effort, that's important for a resource point of view. If you're spending unnecessary energy, you're not being efficient. If you're not being efficient, that energy and those resources can't be used to tackle other problems. And so the importance, like why we have M&M conferences, the morbidity and mortality conferences, to assess what we've done better, stronger, faster, more efficiently, so that we can minimize casualties, minimize morbidity and mortality, is because there's a monetary cost to this. There's a life cost to this, and we don't want people to feel like they're experimented on. Plus, institutions can't stay alive if they're spending money on lawsuits. People can't go out and serve the community and take care of their families and be of service to this environment as an ecosystem if they can't maintain certain executive functions like going to work and taking care of themselves and taking care of their families. And so when we look at patients, we're excited to make a diagnosis, But the real point is like, how do I get you back into doing something that you enjoy, that's doing something that's supportive for you and your family, because that's why you're here. And we go, oh shit, I was thinking we just needed to make a diagnosis. And we're excited because we get the diagnosis, we're excited because we get that intervention. So you've got to think through why it's important that we be efficient, why it's important we be effective. You know, even from the support, if I'm using a lot of energy to fight somebody, you know, I don't have any energy left over to fight somebody else when another adversary comes my way. And so, you know, literature is in life, business is life, martial arts is in life. These are things that are going to be important for the programming and the patient care that you provide in the future. So we started our school intervention program first by accident. Hospital program came after and started bringing in volunteers from the community because these are people I knew. You can get your friends and family to do stuff. A community program came about because there's some people who being referred to us, they were like, man, this person would be great for your program. I was like, yeah, but they don't go to the school we work in. They're not a patient in the hospital. And then I realized, I was like, shoot, I guess we got a third program. That's our community program. And that kind of gives us a lot more the leeway to work with people in different spaces. One of the medical students, I forgot Carla's last name. Carla was a med student at Downstate, and then she went on and did emergency medicine with us. She said, Gore, I want to help your program. I was a physical therapist and I used to work with youth. I want to help out. I want to do some workshops. I was like, Carla, you're a third-year medical student. You ain't got no time. I was like, you thought you were busy before. And when you're doing any kind of intervention, especially with a vulnerable group, you've got to be consistent. That's why I think it's so important, like with pediatricians and primary care and internal medicine docs and family medicine docs, they're able to build the rapport. We see patients all the time in the ER recurrent because they can't get into you guys' clinics sometimes, which is great for us in terms of building rapport, but that means that it's a broken system because they're seeking emergency care. But you want to make sure that you have those levels of rapport and keep doing that stuff on an ongoing basis. And as a medical student, she wasn't able to do that. But I thought all the kids, all the guys in our school-based program were failing, except for one, no, two. But everybody else was failing and about to flunk out of high school. The girls might be fighting and dragging somebody down the hall and beating somebody senseless, but they were at least passing their classes. And what is one thing that OCD medical students know how to do? They know how to study. They know how to organize. And I said, Carla, can you guys create an academic enrichment program for the students? And she was like, yeah, let's do it. They did it 2 months before school was out and prevented a series of kids from flunking out of high school and getting put out. And that's kind of part of the success early on. And through them, they started getting graduate students from Downstate, working with them. My mother worked with them and tutored. She's a retired teacher. We had other friends coming in. All you need to do is start, and then you start showing what it is you're doing and continuing to try to improve, and then these movements start to grow. And now here we are. This is, 15, 16 years later from us actually having the name copy to actually having a programming that's serving the entire borough. Hospital intervention program. We have 7 school sites that we work with in and around Brooklyn. We have community programs that are in and around Brooklyn. We service 2 public housing units in downtown Brooklyn, and we're doing education and training, and the movements are growing. The book itself is kind of my story with troubleshooting and problem solving and growing up in Brooklyn, but it's kind of serving as a template to kind of see how things can work, how we implement programs, how we fail, how we learn to understand our environments, and more importantly, how do we make sure we provide services to people who are very, very vulnerable and put them in positions of power that allow them to thrive. I want to thank you guys for coming today and listening to me talk and hearing about parts of the story, but I would love to open the floor up for any questions or discussions.
If anybody has any questions, you could take the mic first.
All right. Nice story, Dr. Gore, really. So my question for you is, when you're talking about treating violence and implementing your program, I'm wondering if is there any implications for like homeland security and national security so that it can get more attention from the federal government? Because, and the reason why I'm referencing this question is because recently I heard on NPR a while back about how there was interagency cooperation between the DOJ, DEA, FBI, NYPD, state police, and they came into the South Bronx and rounded up a lot of gangs, and they said they were drug dealers, violent offenders, and a lot of gang members, Bloods, Crips, all of that. They rounded them out, and the last we heard of them, they were all locked up. And so, and then you never heard any problems in the South Bronx again, at least not recently on the news. So I'm wondering, is there anything that you're doing that's grabbing federal attention to see how we can like reduce the violence other than just with, you know, police and law enforcement?
Well, that's an excellent question. Actually, Dr. Mark and I talked a little bit about restructuring and thinking through programming with different administrations in the government. When President Obama was in power, there was a lot of emphasis on Black and brown programming, particularly young men in vulnerable communities. When Trump came into office in 2017, all that stuff shifted. And we weren't receiving any kind of federal funding at the time. But it was the federal government has an impact on what allowed the local foundations to start to fund, what the city agencies start to fund. And so we started looking at STEM and STEAM education and looking at other interventions and ways to continue to work with our population, but without saying it's Black and brown programming. Right now, like looking at stuff with the DOJ, I'm not a fan of the law enforcement models of containment. Because that doesn't fix the problem, it contains it in a way, and then when those people go back, then you have something that is uncontrollable, and it wreaks havoc on families and communities, much like it has been since the period of time, and people have been containing folks. In order for us to really be effective at what we're doing, we have to look at a lot more primary prevention stuff. I often talk about just social determinants of health. If people aren't familiar, there are a number of public health people, some people aren't, but social determinants of health are the non-medical things that impact our overall health and well-being. And that includes accessibility to school, education, food, or healthy food, social support systems, access to health care. And when one of those things is out of whack, everything winds up being out of whack with a person's care. So you kind of have to address these things on multiple levels. When you start looking at how do we support people who might be considered vulnerable, those are like primary preventions. Once somebody always has a bunch of risk factors, it's that's a secondary prevention. When they've already been injured, that's a tertiary intervention. That costs a lot of money. But if you're looking at what people like to refer to as crime prevention, it's really kind of giving some of the people the things that are essential for their survivability and for them to do well. Violence itself has three different components. There was a Norwegian sociologist named Johan Galtung, and he described violence almost like this iceberg. At the top of it, you've got direct violence. The middle, you've got cultural violence. At the bottom, the base of the iceberg, you've got structural violence. Direct violence, that's the stuff that we see. Those are the injuries that we take care of on an ongoing basis. Those are the verbal disagreements that can be very heightened that are all too frequent in our emergency department. Then you've got cultural violence, and cultural violence is using any aspect of culture to validate both direct violence and structural violence that can cause harm. So this is how, when people are using language, they're using arts, religion, and other societal norms to justify a violent act taking place. Like when somebody calls a particular group of people untouchable, or when members of a particular group use biblical references or any kind of religious references to denounce members of the LGBTQIA community. And then with structural violence, this is really like the systematic way in which social structures, anything like government or any kind of institution, can cause harm by prohibiting the accessibility of things essential for their survival. So when you restrict healthcare, when you restrict education funding, when you restrict legal rights, when you restrict political rights, these are things that can cause major harm. And so we've got to become very creative in looking at some of these structural issues. And structural violence, like direct violence, that's the stuff that you see. Structural violence is hard because there's no particular player. And that's why it keeps happening over and over again. So what we really need to actually target is structural violence, but you can't really call it structural violence, because if you call it structural violence and you say we need to focus on these aspects of government because we're restricting the flow of these things essential for people's survivability, then they go, oh my gosh, no, that's DEI, because you're focusing on Black and brown populations. And so we're still trying to become very creative at what this looks like. A lot of this stuff may actually be workforce development, and maybe looking at how do we cultivate job opportunities and economic resources within this particular community, because that's directly tied to, how well communities thrive, because you've got different kind of tax breaks if you have businesses up and running, if you have different kind of tax structure, if you have different kind of taxable income for people in a respective community, that money can go to education. But right now, all these different models are coming under fire, and are going to wind up being shifting even more so to the point that we really don't know how to target it yet. Especially if, with the Department of Education now under fire and possibly being disbanded, we got to get extra creative. The first thing I think, and one of the main steps is, what do we do? Need to organize in an individual and a collective space. Who are the people we work with? What are the communities we already have accessibility to do? What are the needs assessments that we need to do for these communities? You can do a SWOT analysis, which is understanding strengths, weaknesses, opportunities, and threats, and finding out what those individuals actually need. I think this is an important thing for us to to gather from our patients. How can we be of help? What are the things that you're doing well? What are the things that you're not doing well? And how do we help support that? I think the answer and really the solutions to tackling issues with violence and trauma in our communities lies within the people themselves. But if we're not engaging with the people and we don't assume that the people can even provide us that information, I think we're going to wind up losing out. Government's job is really to exist and maintain a level of stability. No, not even stability. It's existing to make sure that certain power structures stay in place. It's not the job of government to be innovative. If it does happen to be innovative, that's something completely different. I grew up doing the grassroots kind of stuff. Dad's a community organizer. Mom's a retired teacher from, taught in Bed-Stuy and Fort Greene projects for a long period of time. I don't think our answer lies in looking at the governments for support. So what are the things that we can do to help strengthen up a lot of these community support systems? And I think it really starts, so for people in the public health space, they know about, you've heard about the social ecological models. And social ecological models look at the individual, they look at their individual support systems, their friends, their family, they look at the institutions that they're a part of, the church, the temple, the masjid, the sangha, whatever it might be. And then last but not least, you have the policies that impact the people and allow for resources to continue to grow in that place, to allow these institutions or allow these spaces to really thrive and the people to actually do well. The policy is a separate thing, and that's more of the stuff that I think we should look to tackle and understand. We wind up attacking policies, and we're looking at doing things in a bipartisan space. I think we first have to start identifying what are the common goals that both parties have, what are the common values that people start to share, and that's the base of operation. When I first started doing violence intervention work, a lot of my talks were about gun violence. Guns. And people are like, yeah, guns are bad, guns are bad. Yes, guns are bad, and yes, guns do kill people. Knives also kill people. We've seen people killed with bats, being hit by a car intentionally. That's all trauma, but it doesn't get the sexiness that gun violence gets. Gun violence became a little bit more sexy because people started to equate things that were happening with mass casualty shootings, as well as what was going on in Black and brown and poor communities around the United States. So then you started to have a common bond, and then you started having the advocacy groups coming out talking about gun violence prevention, guns, and gun advocacy, because you had a common enemy. But what we're seeing right now, the underlying cause of this stuff is not the guns. There's a whole thing of understanding how do we process trauma, how do we process stress, and that comes to whether or not we have systems that are in place that allow us to be able to do well. But when you're doing things in a bipartisan space, a friend of mine is a Black dude ex-military, went to law school in the Dakotas. He's West African, and he's gay. So he checks off a lot of different boxes and a lot of different groups that you wouldn't necessarily think that he would be a part of. And when he and I were talking, we went to college together. He said, I know you're trying to do, I was trying to talk to him because he worked for Target. And I was trying to figure out how do we engage in public-private partnerships or PPPs. Anybody ever heard of PPPs before? All right. So you have businesses and then you have organizations. And if you're a nonprofit organization, then you can get a tax break as a business. And so nonprofits are really just there as tax breaks for rich and affluent folks. You don't need to do community change work as a nonprofit. So don't think you can do that. There are other ways to be able to do social change work for profit, make it easier, and not have a lot of the paperwork and headache and hassle. There are B Corps that are out there, like Patagonia, Cotopaxi. I learned about the founder of Cotopaxi is one of my friends. We did a fellowship together, and he said you can do a lot of social change work and still make a profit, and then be able to reinvest that money in a different way without thinking that you only have to have tax breaks to do that work. But my friend who checked off all the boxes, he says, I went to law school in South Dakota or North Dakota. And he said there are a lot of people who have farms. And these people aren't all affluent, and they have bandits and people who rob these farms and do all sorts of stuff. And if something happens, you have to call law enforcement. He said it takes like 30 minutes for people to even get out there. These are super, super rural communities. So we start talking about gun violence and gun reform and taking people's abilities away to be able to protect themselves and their families. What do they say? They don't understand the stuff that goes on in central Brooklyn. And I was like, hadn't really thought about it from that point. And he said, so what's the underlying things that are going to connect them? And so I started looking at understanding trauma. We understand what it means to be safe. You want to make sure that your families are safe and taken care of. And so those are the angles that you start entering when you start to, if you're looking at like violence policies, safety is something that everybody wants to have. And so what are the things that can provide safety? Parental training is a way that you can provide support for families early on so that you don't necessarily have to have them enter the justice system. If you have pre-parenting, that means the family unit winds up staying intact, or whoever's taking care of their kids. It doesn't have to be the traditional mother-father. It can be whatever that new dynamic might be. But if you provide support early on as a primary prevention, the likelihood of them staying around a lot longer is a little bit higher. So I started thinking about all this stuff. I started speaking about trauma itself, which we often think about as just being the injury to tissue brought on by some sort of external force, but we know that trauma is much more than just a physical process. It's a mental process with psychosocial consequences, with physical consequences. So we started looking at what's the causality of trauma? What are the underlying risk factors? And so my talk started to shift and to change because it was able to allow us to reach a different kind of audience. There was not really making it more palatable. Yeah, actually, no, more palatable, but it was also looking at what the big picture was. A gun itself is a tool and is an instrument. And yes, there needs to be restrictions on that. So when we started talking about gun policy, and I started incorporating that in my talks in some of these bipartisan spaces, I said, well, what's it like to make sure that safety is maintained, at least with guns in the household? How do we have better laws to ensure that, both criminal background checks are instituted? What's it, NCIS, the National, I think it's NICS, National Institute of, I'm having a brain fart right now, but they do a lot of the background checks. I think it's NCIS or something like that. And, what does that need to be in place? How do you start to do more gun safety for people who have guns in the household who rely on it as protection? I talked to Dr. Maurice Selby, who's, a downstate grad, emergency medicine, downstate for medical school, and he works in Atlanta. He said, we have so many people coming in with injuries because of guns in the house. We ain't even talking about people being attacked. We're just talking about people don't have the safeties on. And so we start looking at it from the vantage point of how do we cultivate safety in communities. And that's something that can resonate with anybody, regardless of whether you agree with their politics or not. It doesn't mean that you don't want to impact this other issues that are tied to us in central Brooklyn, but you look at what this common and core value is, and how do you use the core value that can resonate with both audiences to actually tackle the issues that are pertinent for your community.
I have a question. So there's recently been an attack on DEI programs, as you alluded to. I'm the beneficiary of a DEI program. I think that they're very, I wouldn't be in the position that I'm in, like, right now here at medical school, if not for DEI programs. I know Kiera, she coordinated a program that I was part of. She's also talked about, the impact that DEI programs have had on our life. And obviously this is in jeopardy right now. So I know that Kavi does the in-school work. And I know in my position, when I would speak to people younger than me, I'd say, okay, look at this program or look at that program. And now all of that is in jeopardy. So how do you, as a leader of Kavi, plan to kind of combat what is going on right now?
Excellent question. I'm a product of DEI program. I went to a historically black college, but I went to medical school at Buffalo, and I'd never been to school with white people until I went to medical school. And I've been in Brooklyn since I was 4 years old. The reason I'm doing medicine is because I had a mentor, a guy named Dr. Answorth Allen, I think he's one of the chief surgeons at the Hospital for Special Surgeries. I met him because I had knee injuries and ankle injuries. And he found out that I wanted to be a doc, and he said, "Oh, you want to be a doc? We're going to make sure you get there." So he took me into the OR. He had me shadow him at the Hospital for Special Surgeries. Now, I didn't realize in 1993 that was a big thing. I was like, oh, wow, he's going to take me to the OR. This is so cool. I didn't realize this is the premier orthopedic hospital in the entire world. And so that became my starting point. I'm like, oh, I know I'm going to be a doc because I got a mentor who's a doc, and he said I could do it. And since then, I'm always with a student. Matter of fact, if I don't have a student with me that I'm mentoring, there's a problem. And they go, Dr. Silverberg jokes, and he said, "Oh, I don't see any of your Gorelings with you on shift." And, because I have them, they have all ethnicities. I have one sister whose family's from Pakistan. I've had students from India, Bangladesh, East Flatbush, Nigeria, Chicago. I've had them shadow all the time. I always have a student because I know how important it is to make sure that mentorship is available. And I'm gonna give them everything that I know to make sure that they can come in and be in these spaces. I got white kids who shadow me. It doesn't matter. I got a student who's from Brooklyn, went to Xavier Prep in the city. He's in med school in Ireland, and he's one of my mentees. Thank you. And I realized, and this kind of comes back to, upbringing. My mother was an educator, father was an activist, and a lot of conversations we would have is, what's your role going to be in the community? Dr. Charles Drew said something to the like. He said, people don't know who Charles Drew was. He's the guy who's responsible for blood plasma and transfusions, and he completely revolutionized that. And he said, you need to go where you're needed most. You need to bring the knowledge and the skills that you've acquired back to the places that have nurtured you. And so we can expect, again, I don't have a whole lot of faith in government. I've never really had a whole lot of faith in government. And I've worked in government hospitals my entire career. So I have to ask you, what's your role going to be? Everybody should have a student that they're mentoring. You should have a series of different students that you're mentoring. We wouldn't be here if it wasn't for folks that were mentoring. I don't give a crap if you got a whole lot of work to do. That is the job. That is what you've been charged with. That's why you're in this position. You know things. You understand things. You've seen patterns. My father said something a long time ago. He said that my grandfather passed on to him. And he said, you're going to make mistakes, but they don't have to be the same mistakes that I've made. And so if we're not actually bringing somebody along with us in the process, why are we going to expect government to fix this stuff? So we are the DEI programs, whether it has a label or not. It does get tied to funding. I ran Cobby for 2.5 years with no money. No money. We had 50, 60, 100 kids in our school program. We were seeing 100 plus clients a year in our hospital program, still lecturing, not getting paid for any of this stuff. But we just brought people together. And before we use money as a transactional kind of thing, these are things that started to happen in terms of us building community. What are the different components of the community? How do you provide those different components of the community? How do you bring people to understand those different components of the community? And if you're looking at it as you need to bring on your replacement in the future, because if not, then your ideas wind up dying out with you, then you're going to figure out a way. But if you don't have a student that you're mentoring, and even as a medical student, so I first started, my first students that I remember mentoring, I started teaching when I was in high school, middle school, high school, because we were doing like student teaching stuff. I taught classes in my high school. When I got in trouble and I had to go to Catholic high school, they had a teacher assistant program. And so I started learning how to give lectures and talks. And so I had kids I wound up mentoring without even realize I was mentoring. When I got to college, I got into an early acceptance medical school program at Boston University. I didn't complete the program because I didn't want to give up my senior year of college in Atlanta. I was having fun. But when I got in, I told folks, I told a whole class, I was like, look, I got into medical school already. There's a lot of stuff that I know how to do. If you have any questions, let me know. And so I started mentoring students from that point on. When I was a resident physician, there's another doc. She's a physician. Katie just left Alabama. She is in Chicago now. I did a talk about communications in the healthcare profession when I was a resident physician. I went down to Texas to visit some people and family and friends, and I had my father had a friend who was at a school of communications at Texas Southern. He's like, "Oh, you should come by. Come talk. I just want to meet you because my son's in medical school." And in the office, I started talking to some people, and this one guy said, "I have a class, communications in the healthcare profession. You want to come by?" I was like, "Sure." Met this one woman who was a graduating senior. She said, "I want to go to medical school. I don't know how." I was like, "Oh, let's talk." She's like, "I'm also from Chicago." I was like, "Oh, I'm a resident in Chicago. When you come home, come visit. Come by." So I snuck Katie in the emergency department. Got her a white coat. I was a senior resident. I probably wasn't supposed to be doing it. But Katie's now an attending physician in Chicago. And she's been an attending physician in Alabama. She just moved back home to Chicago to be closer with her family. There are hundreds of stories like that. I didn't do it for any money. I did it without anybody even telling me. And so you got to figure out, are you asking yourself for permission, or are you just going to do the work? Are you asking other people in leadership to actually do something that you know is the right thing to do? And that's something we can't just go to government for. It doesn't mean we don't fight to get funding and resources and make sure that people understand why it's important for diversity, equity, and inclusion to be of most paramount importance, because it's not, some parties just think this is just a black and white thing. But it doesn't mean, people don't think about diversity, equity, and inclusion meaning they're veterans, people who have physical challenges, women, even just the complexity and the diversity of neurodivergence, that's also included. If you didn't have some of that stuff going on in Silicon Valley, shit, a lot of stuff wouldn't be going on. A lot of companies wouldn't be up here. But people don't like to include that. They want to make it a black and white so you can actually create adversaries against one another. So we've got to just be really, really mindful of are we asking people for permission to do this work, or are we just trying to get more support for the work? And like what happened with us is that you just got to go ahead and do the work. I got money when we first started MMSEM. I got funding for 2 students. I wound up having 7 students. They came from all over the country. They slept on people's couches. They commuted from New Jersey. They stayed at friends' houses in Long Island. And they kept coming. We wound up getting a little bit more funding and support, but we had some sweat equity involved. We'd already been doing some work. And so when people start seeing that you're doing the work, and you do it whether you have money or not, then resources start to come your way. Thanks.
Hi. Thank you. Thank you so much for this talk, Dr. Gore. I feel like y'all been gatekeeping him. I am a third year now. I'm like, where were you? But first off, I have 2 questions. One, I'm glad I came to this talk because I think I had a misconception of what CAVI was. I thought it was, and correct me if I'm wrong, like a Black male initiative against gun violence. That's what I originally thought. Now I have a little bit of a better understanding, but I'm curious. We talked about, trauma and violence from different things. Does your program focus on violence with, let's say, like female abuse? Like where does violence and female students come into play? And then my second question is, what does the hospital component of CAVI look like now? It sounds like you're in schools, but do you have students like come to the hospital and shadow like the high school students?
That's an excellent question. So hospital program, school program, community program. Hospital program works with people who've been shot or stabbed, who come in and are victims and survivors of violence, or any kind of an intentional act of trauma. There are sharp delineations with the patients that we treat because you have social workers in the hospital. Everybody's territorial. And remember, when you start looking and doing things that anytime you enter a space, you got to do your assessment. Who's already there? What are they doing? What are they doing well? What do they need support with? And when we first started doing the work in the hospital, social workers were upset that we were there because this is our domain. You're doing social work stuff. So yeah, but you guys don't like dealing with young men and young survivors of violent trauma. They would work with people who were domestic violence or partner violence survivors. They would work, we already had the SART program for sexual abuse, the sexual abuse response team. But when somebody came in, shot, stabbed, beat up, there was a young man who might've been gang related, gang affiliated, everybody's scared. And they go, you know, just stay safe. And so we were there to kind of fill a void. And right now we do the intervention work to make sure there's no retaliatory violence. And so we have hospital responders and an intervention team who meets with people in the emergency department when the patient comes in. They work with the families right when they come in, and they work with their social circles and do the follow-up and case management work when they're on the floors and upon discharge. And this might include anything from helping them get a safe space, especially if an incident took place before they came. Incident took place in their place of residence, like right out front of their apartment building or their house. We've done that with some of our community partners. We will help get somebody get an ID card. Some people like, man, I don't have a job and I need to get a job, but I don't have ID. I don't have this. I'm undocumented, whatever. And we help people navigate that space because we know what's important to help get them certain protective factors. If you don't have food, clothing, shelter, and security, how can you survive? And so that's of utmost importance. You know, there was a rapper named Mos Def said, people don't like to see black smoke. People, Talib Kweli said, people don't like to sell crack because they like to see black smoke. People sell crack because they're broke. And so if we're addressing things that are tied to economic survivability and economic access to resources that are of an economic realm, then people tend to do better. But you've got to get people the tools, and sometimes people don't have the tools to navigate that. In addition, we have behavioral health resources, which is of utmost importance. If you've already been traumatized, I'm sure you're probably dealing with anything from an acute stress response, acute stress disorder, or even PTSD, and you might have some underlying depression and some anxiety around those entire situations. When that continues to happen, you're dealing with a whole other complex issue, and I think we don't often understand how to process the trauma that we've experienced. And so that's what our team helps people do. They help them identify some of the triggers and the traumas that they've experienced and then see how we can direct them into the right places that allow them to process that. And so we are kind of a conduit to these different resources that are going to help them make sure they don't come back as patients. For our school program, we work with kids who are considered to be at risk. That's any kid who comes in, everybody lives in East Flatbush is technically at risk, or goes to school in East Flatbush is at risk. But we have that, most of the kids have had histories of frequent fighting and doing poorly in school. They've been have gang involvement or gang affiliation, which again is a big part of anybody who lives in Central Brooklyn. You're going to have an affiliation. You may not want to be bothered with them, but you know who people are. You know who you need to keep on your side to stay safe. And we have both guys and girls programs, and we have a CAVI royalty program, which focuses on members of the LGBTQIA community, LGBTQIA plus, and their allies, because they need support. And a lot of the kids in our program may not have had any issues with violence, but they're navigating a lot of the trauma that exists within their community. And they need a safe space or a brave space to be able to process that. And then our community program kind of fits all the above. How do we support you in the community after an incident of violence has taken place? There are healing circles that are provided. There are community events that focus on education. So like yesterday's event at BMCC, and a couple of months ago, it was helped sponsored and put on by one of our community health directors, because talking about violence and educating people in the general public who aren't necessarily patients or participants doesn't mean that they shouldn't have access to resources and a way of understanding. The other question you had was tied to what do we do in terms of violence against women. If somebody's been shot or stabbed, then our team gets consulted. If it's just physical, if it's a blunt trauma and it's an assault of nature, we aren't always consulted unless the social work team wants to do that. The social workers were already seeing the partner violence, and that's something that we decided a long time ago to make sure that we don't take that away from them, because I still think it's very important that people have something that they're a part of, that they own, and if it's some outside agency that's coming in and taking over. Remember, CAVI itself is a nonprofit. We have a nonprofit in the hospital for some political reasons, but then other people also don't like us because I'm an employee and we have a nonprofit at the hospital. This doing community work, that's a separate question to talk about. But if somebody, like there was a woman that was shot, no, actually it was a man that was shot and came to the emergency department as a patient. And we were consulted and we were part of the team. And then we wound up finding out through one of our intervention people, Taisha, who Dr. Gist knows is one of our violence intervention specialists. She determined that it was actually, the person was shot because of a woman. And it was also tied to some sort of a domestic thing that was going on. And so now, yes, it's an interpersonal violence issue, but now it's also a partner violence issue. And then there was a woman who was a part of that whole thing. The reason why she had shot somebody because there was might have been some sex trafficking tied to that. So you have a interpersonal act of violence with a possible partner violence and this tied to partial sexual violence. And so we were there as a united front with the sexual abuse response team, the social workers, and our violence intervention program, CABI, that's kind of working on that. And a lot of times you need different people to help tease out things. The reason why we have nurses, docs, consultants, social workers, mid-level providers is because each of these people and each of these groups provide layers, safety net to make sure that things don't fall through the cracks. This stuff the nurses pick up all the time is like, woo, I'm so glad you picked that up from that patient. Or something a medical student says, I'm like, dang, I'm glad I listened to that medical student, even if they were talking a whole lot on shift. But they had something of value. So you want to make sure that we strengthen these different safety nets, and we're part of this more comprehensive network of safety nets.
One last question. So for it's okay.
No.
So for the school program, as CAVI is growing, have you guys began or have you thought about tracking the students that you work with in the school intervention part once they graduate high school and like what they're doing after?
Excellent question. We are tracking data. We're a lot better about tracking the data now. In the early days when we didn't have any money and me and Dr. Gist and a bunch of other people were doing this stuff with very little or no money, it's kind of hard to do all that stuff. We do have partnerships with SUNY Downstate School of Public Health and Dr. Fable, and I'm having brain farts of some of the other people. What's Tanya's last name? Dr. Taylor. So their number, and oh man, this other guy, light-skinned guy, bald head. He used to be here. I think he's in Michigan. He might be in Michigan now. But Michael Joseph, thank you. So he's in Columbia. Okay. Okay. So these are all people who have been intimate parts of our team from when we, not just when we started, but a little bit later on, and have been helping with the downstate students in the School of Public Health doing data tracking as a part of their regular coursework what's the program called, Dr. Gist? Apex, thank you. Dr. Gist, I'm not sure if you guys know Dr. Gist. Dr. Gist is a part of one of our team members. He's was our clinical director for CAVI. He's also the director of the PICU, and he was responsible for helping create the Apex program with the Downstate School of Public Health, and so we want to thank him for that. But we have been doing the data tracking from start to finish now so that we can make sure we have that comprehensive data.
Thank you for coming back to Downstate. It's an honor to be in the room. I guess my question comes back to, I guess you, in a way. What is your guidance about cultivating, I think it's a sense of humility that you have to develop within yourself, just like for failing as part of a process to a higher purpose. And then I think as part of that, you're navigating an incredibly traumatizing landscape that cuts across everything that means the most to be human and injustice to it. And so I'm imagining that there's a lot of rage. It could be very triggering. So what do you do? What is your guidance for self-care? Because that's something that we try to cultivate among our medical students. And because as some of the patients that have come back to speak with them have told me, you're a useless doctor if you're not taking care of yourself. Right? You have to tend to your self-care first, because then I know that you can provide for me too. So just some thoughts on that.
Excellent Excellent question. Self-care is something that I had to learn the hard way. I think I've always exercised, and I think had I had a clinical diagnosis as a kid, I would have been diagnosed with ADHD. Like most, matter of fact, our entire emergency department would probably be diagnosed with that or some form of autism spectrum, because you got to be able to process information and be okay with being interrupted. Derek, thanks for coming. And movement has been something that has been important for me. My mother's a teacher, and I was like the only kid on the block that didn't have to do his homework when I came home from school. She's like, you've been cooped up in school all day. You've been on that bus, pretty much all afternoon, because, coming from East Flatbush down to Fort Greene, it took a period of time. And she said, you weren't going to pay attention. You're just going to cause trouble. So you need to kind of get that energy out. Now I know the science behind that in terms of regulating your nervous system. And so movement is a major way that we can do that. Vestibular movement, proprioceptive movement, the running, the jumping, all that input actually creates biofeedback that allows us to be able to regulate our system and be able to think through things a lot clearer. My mother, when I was a little kid, I learned how to do sun salutations. My aunt was actually married in an ashram, and so we'd go to the ashram with her and start learning about yoga and meditation and chants and all this kind of stuff. I was an interesting little kid, so you start learning what these things are. And I also like to watch a lot of karate movies. It's not karate, I should call them martial arts movies, but we call them karate movies in the 80s because we were ignorant and didn't realize that this is all something very different. And make sure it's not the kid. Nope, spam. And with the karate moves, I always liked how people were able to kind of harness this chi, or whatever they called it in whatever movie. I was like, man, they would sit still and kind of get focused and centered. And I thought it was the coolest thing on the planet. There was a movie that was called The Last Dragon, and they had a dude named Bruce Leroy, who was this black martial artist from Harlem, and he got this glow. So I was like, I got to sit still like him so I can get the glow. And then this is also the 70s and 80s. You had Star Wars. I was like, man, I want to be a Jedi. And they're sitting there meditating and doing all this stuff, trying to harness the Force. And so I would sit there as a little kid trying to do that. It wasn't for long periods of time, but my parents didn't argue. It's like, shit, he wants to sit still for a little bit, fine. He's not wreaking havoc on the house if he's sitting still. But over time, it became something that I was like, wow, I like doing that. I like how I feel when I do that. And I always like this physical activity. So my physical activity hasn't ceased. I've had the same level of intense physical activity since I've been in high school. It hasn't stopped, which is probably why I'm pretty much like almost the same size that I was in high school. Probably about 15 pounds heavier than high school. But I have to move. If I don't move, if I don't train, if I don't meditate, if I don't lift, if I don't train martial arts, I can't focus. But I also realize it's a way to process the trauma and the stress. There are a few things in terms of stress. We learn about homeostasis in biology in our first year of medical school. And you basically maintain this internal environment that allows things to kind of stay nice and to function properly. But then you have something called allostasis. And allostasis is our body's ability to adapt to the different stresses that are presented on the outside. Whether you're in the outside elements because of heat, cold, even residency, medical school, public health school, dealing with your kids, there are different forms of stresses that you wind up, learning. Now, when you have these periods of time where you're able to process what you've done, you've had that rest, you've had those respite periods, you can grow from that. And adaptation becomes very important when we're learning how to deal with stress. We don't want to be these majorly strong edifices that are impenetrable and unbreakable. But as history teaches us, as literature teaches us, I remember like Antigone, they talk about like there's a tree that bends and sways that survives the storm, and things fall apart. They were talking about like Okonkwo, and they're talking about hubrisness and excessive pride and being so fixated in your ways that you wind up breaking. And so how do you wind up adapting to these changes that are presenting themselves as a part of what it is that you're doing? And you have to have those periods of respite. You got the stresses that come from our internal environment, which is what we ingest. You have the stresses coming from our external environment. And so you got to have that balance of, can your body process the things that you're ingesting? Because if it can't, that creates more stress. Now, now we know that all this stuff is tied to our gut microbiome. And so we eat a lot of crappy foods and stuff like that. It disrupts our gut microbiome, which is considered to be our second brain. And it impacts how we engage with people. It impacts everything from depression, anxiety, and it's all tied to what we eat. And then we drink Celsius drinks. No shame on to emergency medicine residents who drink that stuff. But we drink Celsius drinks and other caffeine and other stimulants to kind of keep us awake because we're trying to regulate our nervous systems, but we don't because it's stimulating. And now we can't sleep. And because we can't sleep, we got to take something to kind of bring us down. So we've had residents who drink, smoke just to be able to fall asleep, but they're popping caffeine pills and all this excessive stuff because they need it to function. You got this yo-yo effect until you get to the point of what's referred to as allostatic load. And that's when the body breaks down mentally, physically. For our pediatricians in the audience, we know about ACEs, or adverse childhood experiences, right? And so, adverse childhood experiences, these are the things that happen to us before the age of 18 that can be traumatic, that can disrupt everything. Somebody has a bunch of different ACEs, it can cause issues with your endocrine system. People wind up having issues with heart disease, autoimmune problems. They're more likely to enter the justice system. They're more likely to experience violence. They're more likely to experience early death. And this all comes back from our bodies, receiving and not being able to process and regulate the stress that we've experienced. And so you have to have these periods of time where you're able to kind of take a step back. You have to have these periods of time. You have to have the stressors placed on you, because if you don't have the stressors placed on you, you're not going to grow. And so I don't want to say you don't become I don't want to say you don't have stressful experiences. You need that. That's how those synapses start growing. That's how those new neural connections start growing. You got to stress them out, but you got to process what you've experienced, and that's different for everybody. You got to figure out what works. And just like with developing organizations, with developing new protocols and treating patients who've got complex issues, you got to figure out yourself. How do I process my stress? How do I respond to and adapt to stress? In 2015, I had a breaking point, and I really started taking it even more serious. I was doing all the meditation stuff, the martial arts, but one of my mentees was killed. And he was one of our first hirees for CAVI, a guy named Willis Young. And Willis was stabbed multiple times on my birthday. So my morning wake-up call on July 22nd, 2015, was that Willis was in critical condition in the ER at Kings County and was taken to the OR. That's what I woke up to. And Willis died 2 weeks later in the SICU, in the same place that he would do a lot of intervention work for people who came in as patients and survivors of violence. And I never took a break. Willis had lived on my block that I was living on in Bed-Stuy, that I currently live on. He grew up there. And so I was the interface between the family and the friends and everything. He worked for our organization. So I'm the interface between the organization and him and everything that's going on in the family. Because he worked inside Kings County Hospital with CAVI doing intervention work, I'm the intervention person, and I'm having all the conversations with the hospital administration, the ER staff, because everybody knew him because he was always with me. When I said I always have a student with me, he was always with me. He was doing even when he was doing trainings and learning about this process before he was official, he was always with me, learning and observing. And I never took a break. The night of his funeral, I never took a break. I worked in our critical care and trauma emergency department on an overnight shift, and I've been up all morning, all day, all afternoon, and I had an 8-hour shift. And I was running late, and I called the ER, and I said, talk to the charge nurse. I was like, what's it look like in there? And the charge nurse said, it's all right. We got a couple of people who got shot, but they're stable, but you know one of them. And I'm like, crap. And she said, remember we took care of his brother. So there's a patient who came in shot multiple times, and I had taken care of his little brother and pronounced his little brother dead after his little brother was shot by the police. When I went into the room, eventually, we start to recognize each other. The mother recognizes me. And after that, she stopped making eye contact. And I had to give updates on what's going on with the son who's there. But she would ask me all these questions, but she wouldn't look at me. And I'm like already feeling like real bad. I'm tired. I'm feeling anxious. And then she asked me, she said, did my son say anything to you before he died? And then my body just broke down, because this is a kid who came in alive and died in front of us. after being shot multiple times by the police department. And I started having panic attacks. I'm having dry heaves. I'm sweating. I couldn't even answer this woman. My mouth went dry, and I ran into the bathroom right next to CCT, and I threw cold water on my face, and I'm trying to wake myself up. And now my body's trembling. I'm shaking. I'm having an acute stress response, and I'm having a panic attack. And I have 6 more hours left on my shift because it's like, I think it was like 1:30 in the morning at this point. And I'm like, how do I function if I'm a patient? And so I kept walking around and pacing. I would tense up my body. I wouldn't sit still at the computer because if somebody saw me sitting at the computer typing, they would see that I was shaking. And we're not supposed to tell people that anything is wrong with us. We're supposed to kind of suck it up and be strong and be and hold it together to function. But I'm a patient now, and the symptoms kept happening over and over again. I'm having panic attacks walking up the ramp, going into the ER, and I can't function. I'm tensing up my body, and so I started going back to therapy just because I needed to be able to process a lot of what I was experiencing. I talk about this stuff a little bit in the book, but the therapist said one thing was really important. That she said a lot of things are important, but one of the things she said, you have to be mindful of empathy. She said, you're so concerned about being empathetic because we're supposed to, connect and identify and understand the pain and suffering of other people. But she said, you're taking on the pain and suffering of others. She said, you're trauma bonding. And we create these trauma bonds with people because we think that's going to connect us. She said, you need to be compassionate. There should be a distance. You don't have to be cold. You can be compassionate and caring. But once you start to feel like, I got to feel this person's pain, it's going to take over you. And that's what happened. I had broken down. And then after that conversation with her, I still went to therapy. But no, actually, I didn't go back to her for a long time because I was like, oh, shoot, I figured out the missing link. I'm trying to create these trauma bonds. So I had to do a lot more things to regulate my system, doing more of the meditation, but really kind of understanding, like, look, I understand, Baba, if you're a patient, I said, I understand that something really bad and really shitty happened to you. And I'm sorry for that, but I don't have to feel like I feel what you're doing. No, I don't have. If I don't feel it, I don't need to force myself to feel it because I don't need to create that trauma bond. I do need to make sure that we're level-headed and that we're coherent and we're thinking through things with maximum efficiency and minimum effort that allow us to navigate these safe spaces and can take care of them. Because if we're stressed out, we can't provide these protocols. We can't do things clearly and provide change. And I don't know if anybody's ever been in the emergency department at the county, but it looks like hell. Downstate looks like hell too. It's always busy. Somebody's always stressed out. Somebody's always triggering. And if you can get a hold of your own triggers and be mindful and have that practice that's built into everything that you do, then you can regulate. And if you can regulate, you can serve people who are vulnerable better. If you can regulate, then people aren't going to really respond to you. When somebody tries to trigger you, you can adapt. Be like, look, I know you're talking to me, but I'm not the culprit, so I'm not taking it personal. And a lot of times when we're in these stressful spaces, and people who have kids, I got a 4-year-old, and my 4-year-old pushes my buttons all the time. And until I understand it about being a parent, what happens and how people can push your buttons until I had a toddler. And I realized it's like, he doesn't know what he's doing. When he's writhing around and he's having a meltdown and stuff like that, or he's having a tantrum, I'm like, he's not present. And I was like, oh, shoot, the language that they're using in the pediatric literature talks about dysregulation. And so my toddler's dysregulated. So if he's dysregulated, that means he's stuck in fight or flight. If he's stuck in fight or flight, he's focusing on survival. He's not coherent of anything in and around him. And so what can I do to help make sure that I'm calm? And I strive to be the calmest person in the room wherever I go, because I know that allows me to be, grab a hold of the situation and understand it and work with efficiency. But it also allows me, if I can be that calming person, I may help bring about a parasympathetic response in him, on the people that I'm around, just by lowering your voice, by getting to somebody's level. When you're the doc and you come up to somebody and you're like this, that puts you in a position of authority. That's a power position. And when you're somebody, if you're another doc, you can be like, shoot, I don't care if he's standing up there like that. It's like, that's some bull. He's just trying to, show himself that he's strong, that he's in power. But you kind of sit down at that level, and you address them in a way that's humane and civil. But look, tell me what's going on. Now we have a different kind of relationship. Now they actually understand that you actually aren't afraid of me, but you're actually here for me. And because I don't feel like there's not a fear-based relationship, even though I'm scared about what's happening to me, I can regulate my system. And that brings them down. Cortisol levels go down, norepinephrine goes down, epi goes down. And now we have a very different relationship. And now we can process the information that's being passed on to us, or that we're learning and they're learning, so we can actually come together and come up with a common treatment.
Unfortunately, we've come to the time where we don't have the room anymore, so we might have to continue this a little bit more informally. But let's give a round of applause for Dr. Gore. Thank you for sharing all your experiences. It's been very eye-opening from a medical student perspective about the work that you're doing in the community. And I'm sure that everybody here is appreciative of the work that you do. And, we're here to celebrate you. So thank you. So.